chronic obstructive pulmonary disease. I believe in the morning we mentioned it. When we talk about COPD or chronic obstructive pulmonary disease, a progressive, preventable, or treatable or reversible disease of the airway. Usually, it's characterized by persistent airflow limitation. And with the chronic obstructive pulmonary disease now, there is chronic inflammation of the airways and the lung tissues. So over time, of course, if not managed, then it leads to obstruction of the airways. So now about the incidence, but now usually it's clinically defined by a patient having daily cough production of sputum at least 3 months per year for 2 or more consecutive years. Remember, I talked about this in the morning, the chronic bronchitis. That's what we have here. Then it is also characterized by emphysema. Emphysema is where now there is a destruction of the alveolar walls, and thus there is decreased gas exchange. Remember, we talked about bronchitis in the morning, the inflammation, the swelling of the linings of the airways. And because of that inflammation, there is stimulation of production of mucus, which can further cause now obstruction of the airways. So that is the chronic bronchitis that characterizes COPD. That's one of the conditions. And now is emphysema. Yes, there is emphysema where there is a destruction of the alveolar walls, which leads to now decreased gaseous exchange. So with the emphysema now, the alveolar walls will lose their elasticity, and that's going to lead to collapse of the bronchioles. We talked about atelectasis in the morning, where we are talking about collapse of the alveolar. So this one, there is collapse of the bronchioles, which will cause, of course, obstruction of airflow out of the alveoli, and that air will be trapped in the alveoli, and that's going to reduce the ability of the lungs now to shrink during exhalation. So, of course, that's going to affect now lung expansion. Some of those risk factors, we can actually classify them into the modifiable and non-modifiable if you want to talk about that. But the most common risk factors, the primary cause or the primary risk factor for COPD is cigarette smoking. So exposure to that tobacco smoke, be it active or passive smoke, usually accounts for majority of the cases of the risk of developing COPD. Still, secondhand smoke, of course, increases the risk of respiratory infections. Air pollution also contributes to COPD. Then there is genetic factors where we have deficiency of the alpha-1 antitrypsin deficiency. The AAT, that is the alpha-1 antitrypsin, usually enzyme is produced in the liver, but is present in the normal lungs. And what is that? It does, the alpha-1 antitrypsin enzyme, is that it protects the alveolar linings from any form of corrosion. So basically, with that deficiency, then the alveolar linings are prone to destruction. And the alpha-1 antitrypsin deficiency is the cause of the emphysema that we've just talked about. Then chronic respiratory infections, alcohol can also increase the risk. So all this is the pathophysiology. In summary, one is exposed to the irritants, which are going to cause airway inflammation, and in this case, chronic airway inflammation. Like we've said now, when there is airway inflammation, there is hypersecretion of mucus, and with hypersecretion of mucus, the airways are going to narrow. The alveolar will be destroyed, or there will be alveolar destruction in case of emphysema, and that's going to cause decreased lung elasticity, and that with the decreased lung elasticity, air will be trapped in the lungs. There will be hyperinflation, of course, within the lungs. There will be decreased gas exchange within the lungs, and then that's eventually it's going to cause respiratory failure. So that's just a brief summary of the pathophysiology. So from the irritants to inflammation to hypersecretion of the mucus, which is going to narrow the airways, the trapping of the air within the alveolar, which causes the alveolar collapse, and eventually respiratory failure. Your signs and symptoms. The most common one, most important one in this case is cough. And you're talking about chronic productive cough. Daily for 3 months in 2 to 3 consecutive years for chronic bronchitis. Shortness of breath, which worsens with mild activity because of the narrow airways. Trouble catching breath, fatigue and wheezing coming in, there's chest tightness, rhonchi on your auscultation. Then, of course, as it progresses, it causes now respiratory failure. Tachypnea, where there's now rapid breathing rate, hyperaeration, enlargement of the chest, breathing through pursed lips, because now one is trying to breathe in as much air as they can. Barrel chest, the barrel chest is because of hyperinflation as a result of the trapped air within the alveolar. Your investigations, um medical history, or the history of the patient. Physical exam, you will see an enlarged chest cavity. You'll also get to hear wheezing on your auscultation. Blood tests, of course, will help you to rule out infections. Again, the enzyme alpha 1 antitrypsin will be low. That's the case you talk about emphysema. Sputum culture and microscopic examination for the mucoid sputum, just to confirm whether there is any causative agent, or to rule out the presence of any causative agent. X-ray, that's chest X-ray. Of course, it will show you those hyperinflated lungs because of the air that has been trapped within the lungs. So that's a sample of chest X-ray with those hyperinfiltrated lungs. So you can see it's more or less like darkness here and shades here from that hyperinfiltration of the air that has been trapped within the lungs. Via bolus, because of still the air that's trapped. CT scanning to help you diagnose emphysema. Still, CT scan for COPD, which will still help you to check for the COPD. Pulmonary function test, again, where you want to just check on the functioning of the lungs. Arterial blood gas analysis, that is the ABG, which again will show you hyposemia or hypercapnia in advanced stages because of the reduced tissue oxygenation for the patient with COPD. Lung volume measurements, of course, which will show you an increase in total lung capacity. Still, that is still on part of your lung function test or the pulmonary function test. Still, tidal volume, of course, go back to your physiology, what type of volume, the total lung capacity, what it is, some of the volume compartments after maximum inspiration. This will basically part of your pulmonary function tests. Complications of COPD, respiratory infection, acute respiratory failure, pneumothorax, more especially if there is rupture of the alveolar that have been hyperinfiltrated in cases of emphysema, ventilation perfusion mismatch. There'll be a mismatch. The body is not sufficiently perfused because of the lessened amount of oxygenated blood that is now going to the body tissues. Hypoxemia, which again can come in because of the decreased perfusion of the body tissues. The call pulmonale, we'll be talking about this as a condition, basically right-sided heart enlargement, which eventually leads to right heart failure because of pulmonary hypertension. And this is because now uh, coming in from now the reduced or inhibited blood flow within the lungs. Mostly can be seen in patients with COPD. Your management, medical management, we want to, of course, focus on the causative factors, manage that, and as well now manage with drugs. Of course, one of the most important interventions for patients with COPD is smoking cessation, because that's the common causative factor for COPD. So smoking cessation, um, and of course your goals there, you want to improve ventilation, facilitate removing those bronchosecretions, preventing complications, management of the patient. So smoking cessation, your number one strategy. Then taking medications that are going to dilate the airways, because now remember that the airways are closed. So you want to give something that's going to dilate the airways. So the bronchodilators come in this case. For quick relief, you can give the short-acting uh, bronchodilators, the salbutamol. Then now for maintenance, long-term maintenance, you can now give the long-acting bronchodilators. Then you can also do vaccination against flu, influenza, and pneumonia, regular oxygen supplementation for your patient, and also pulmonary rehabilitation after patient has recovered. Then you can also give oral corticosteroids or the inhaled corticosteroids just for acute episodes of COPD. Antibiotics, once you have done the culture test, if there is any form of bacteria. You can give also mucolytics just to thin the secretions if need be. So smoking cessation, your most important treatment for COPD. Bronchodilators, the beta agonists, the albuterol, salbutamol, uh, and the various bronchodilators that you can give. Um, Again, corticosteroids can be given into this patient because it's an inflammatory disease. Oxygen therapy, if it's required, then you can put your patient on supplemental oxygen postural drainage, which is going to help you expel the secretions, control the complications, the edema, the colpulmonale, so you get to manage that. Phlebotomy, just to try to reduce the cardiac workload, antibiotics if there's any infection. Promote exercise, aerobic exercises for your patient, just to mobilize the secretion for expectoration, and at the same time encourage diaphragmatic breathing and passed lip breathing so that you can have as much air getting into the lungs as possible. Then improve the general health of the patient. Stop smoking, avoid exposure, avoid high altitudes, use supplemental oxygen, regular oxygen therapy, just to maintain. Your nursing care, the obvious ones, history, taking, arterial blood gas analysis for your patient. You want to see the oxygen saturation levels within the body, the respiratory rate, the depth, the characteristics. You want to look at the sputum amount and type. Anxiety for the patient, access it and intervene appropriately. Your nursing diagnosis, you have so many there. They are the same again, impaired gas exchange. Your interventions, which will require you, of course, to assess the respiratory rate, notice the use of accessory muscles, if they promote passively breathing, inability to speak, as your interventions. Um, there's so many here. Activity intolerance because of inadequate oxygenation and dyspnea. So you want to improve activity tolerance within the period the patient is within the hospital. So you got to manage that. Ineffective airway clearance related to excessive production of secretions. So your goal here is to make sure that you maintain a patent airway, clear breath sounds within the time the patient is within the hospital. So you monitor the respiratory rate, auscultate, assist the patient to assume a comfortable position, like elevating the head of the bed, sitting by the edge of the bed. That's going to help to mobilize the secretions, maintaining environmental pollution to a bare minimum, administer medications like the bronchodilators, and facilitate chest physiotherapy. Anxiety, you want, of course, to manage the anxiety of the patient. So provide a calm, quiet environment. Uh, Explain the patient about the disease, the cause, the signs, the medications. Allow the patient an opportunity to talk and express their feelings about their present conditions. Risk for infection. So you want to minimize the risk for infection. Teach the patient how to wash their hands, how to care and clean respiratory equipment that they are using at home, how to assess the vital signs as part of your interventions. Thank you. Any question?